So 5 foci, 0 compromise. I'm Ruth Lapid from Amsterdam, the Netherlands, and I've been using this lens for 5 years now, and it's actually the basic lens that I use. Explaining shortly how this lens works, it has 5 foci, and the foci are spread like this, that you have one for distance, intermediate, and for near, and in between we have the intensifiers. They are the sauce on the dessert. They make sure that the light gets amplified for all the other foci, and this is what makes the defocus curve so incredible from near to distance for this lens. In terms of what this intensifier also does, it allows you to get more light to each of the foci, so the MTF is higher, and this means that this lens has the highest translucency of all multifocal lenses that are in the market now. We're on 93.5. There's no other lens that does that. My database is not complete, so I'm only going to bring you the data of 497 eyes that we did in the past 2 years. And the mean age, as you can see, is 58 years old, and that's because we use it for refractive lens exchange. Not all my patients have cataracts. Pre-op, they have next to nothing in terms of refraction mostly, but this can be widely spread from +6 to -8. And the uncorrected visual acuity before surgery is like really bad. They need their glasses, and that's what they hate. And their corrected visual acuity is actually very good. It's better than 20/20, and still these patients come and seek out surgery. This is the biometry of those eyes. So here you can see that it's more or less in the range of normal eyes. Some are a little bit shorter, some are a little bit longer. The mean is quite normal. And the mean IOL power that we use is 21 diopters. That's completely normal, real-world data. Now, in terms of toricity, we use toricity based on post-operative astigmatism, what we predict, the PRA. And as you can see, that the cylinder most used is a 1 diopter cylinder. It's a very low cylinder, but it's the one that gives us the best outcomes. Here you can see the cumulative Snellen visual acuity chart, and the fun part here is, like, this doesn't look so good, right? But this is better than 20/20, and that's the secret. So I have 31% of patients who have a better than 20/20 vision for far after surgery without correction, and 10% even have better vision than that. Like, these people become youngsters again. Then you can see that uncorrected 20/20, we have an 87%. Corrected, we're very near up to the 100%. Now, in terms of 3 months post-op, how well are our patients doing? Remember, they're refractive cataract or refractive lens exchange patients. Their vision is usually very good, and then they come in and they want to have better vision, right? So we can see that the same visual acuity as corrected before the surgery we have in 2/3, and in nearly 1/3 of our patients we gain lines. And that's good news, I think. In terms of spherical equivalent accuracy, you can see that 51% are around emetropia, and then we have an equal distribution around this. 92% come out within half a diopter. That's really much more than you can see for the Eurequo. If you look at the literature, in the Eurequo literature, we see that 72% of all cataract patients come out within 1/2 of a diopter. We can get up to 92%. Then, in terms of the refractive cylinder, we're not interested in cornea cylinder. We don't look through our cornea cylinder, we look through our refractive cylinder, and that's the reason to use low toric IOLs. And here you can see that 84% has less than 1/4 of a cylinder, like that's more or less 0 in my mind. And just a few of them have higher cylinders. Until now, we haven't had to do touch-ups for these patients. This is the defocus curve for my patients. It's of course not 500 eyes, it's a little bit less than that. But the main thing is that you can see that the binocular vision here in the blue line, it has a peak for the distance, which is logMAR minus 0.1, that's like 2015. And then it goes down around the 2020 line. It has a logMAR 0.03 for the intermediate. There is no other lens in the market that gives this intermediate at this distance, and then we go on. But when we look at it in a different way, I put the line up here for where is this defocus curve highest. And what you can see is we don't go under 2020 minus 1 letter between plus 1/2 and minus 275. And this is what gives us the full range of vision. It's a full depth of focus with a very high MTF, lots of light coming in. The monocular review again shows you that negative is positive in this way. It's logMAR. logMAR, the better it is, the smaller it is. And you can see that for the uncorrected visual acuity, the uncorrected near and the corrected near, we have an intermediate, we have excellent results in terms of visual acuity. All negative logMARs, which is positive. Then with the intensity toric, we did the same thing, and we're showing you again that we're having a very good range of visual acuities for distance, intermediate, and near vision. When we go binocularly, of course, we have summation. If we're lucky, we have 2 eyes and we can use them both, and this gives us binocular vision. And here you can see that as a mean, our patients have a vision that's better than 20/20 for the distance, better than 20/20 for the intermediate, and better than 20/20 for nearby. And now the change from pre-op to post-op. Our patients are demanding. They come in with very little cataract or just with, I hate my reading glasses. So what we do is we make them free of reading glasses. And here you can see that the uncorrected distance visual acuity, they gain at least 3 to 4 lines of vision, uncorrected. On the intermediate and the near, we have no pre-op because we're too lazy to measure that. Now, if someone is clearly a hypermetropic presbyope, we don't do that because it's a waste of our time. We have to be very efficient. Now, in terms of binocular visual acuity, pre to post-op, again, you can see that for the distance, our patients binocularly, they gain 2 lines in uncorrected vision, and they gain on the corrected visual acuity, they gain a little bit. The conclusion from this cohort, and this is actually my take-home message, we check for spectacle independence. So we have a 99.2% spectacle independence, and this is for all distances, far, intermediate, and near. No more readers. I wanted to paraphrase Bush, read my lips, but no, it's no more readers. In any case, the logMAR visual acuity is better than 0.03 between plus 1/2 diopter to minus 2.75. Our patients are very satisfied. We haven't seen any major post-op complications, and we see a significant improvement in uncorrected visual acuity at all distances. Now, of course, when you do surgery, sometimes shit happens. Things happen that you did not plan there to be. And this is usually not something that we want to discuss, but I'm going to discuss with you the posterior capsular rupture that we've had since 2011 until now using the Hanita type lenses. So we had many hundreds of patients and we have 5 eyes in total. So all in all, we're doing well, but when this happens, you need to be able to do something. Now, this lens, the C-loop lens of Hanita, which is the full range MF or the intensity It is very smartly designed. So this is the only multifocal IOL that fits in the sulcus. All the other companies have taken their three-piece multifocal lenses off the market. We have nowhere to go if we rupture a capsule, but now we do. So this lens has a 5-degree angulation between the optic and the haptic. And this is why it's a one-piece lens that fits into the sulcus. It allows for a very snug fit because the 5-degree angulation fits the optic posteriorly towards the capsule, towards the rhexis. But because of the angulation, we don't get the iris chafe, and that's why you can put this in the sulcus. So we're going to describe our small cohort of 5 eyes. I'm very happy it's only 5 eyes, and I will show them to you. So the funny thing is they're all males, and then 3 in the right eye, 2 in the left eye, and the mean age is 53 years old, from 46 to 59. We had the primary posterior capsular rupture in 2 eyes. I had one patient coming back with a late capsular contraction after 11 years in which I had to do something. And I had one patient with a non-ophthalmic eye, 19.3 millimeters. And here I primarily put the lens into the bag, got some stretching, a hyperopic result, and together with Eli Dahan, who is since deceased, but we discussed together, and he told me, just transfer the lens to the sulcus. And this is what I did, and this patient actually got excellent results. So here you can see it summarized in terms of visual acuity. And you can see this is in decimal, not in logMAR, that the average uncorrected visual acuity before surgery was 0.7 about. Corrected, they came up to a higher visual acuity. And then post-op, their visual acuity actually came very near to 20/20 and higher than that. Then in terms of refraction, you can see that the mean spherical equivalent before surgery was myopic, and post-surgery we come out on about -1/2. So we solve the refractive error that existed, but in some cases we put the lens a little bit more forward than we intended to, so we do induce some myopia, which we then treat with a touch-up. So the conclusion of this use of the Hanita SL, the C-loop lens platform, is that we have shown that it's feasible. So we're in a refractive clinic. We have those lenses on consignation. They're in the drawer to use when we need them. And after we rupture a capsule, do the vitrectomy, we have a standing rhexis. I just put these lenses into the sulcus. I discuss it during the operation with the patient. They know that this can happen. And then afterwards, we treat whatever refractive error there is. But in any case, they have a multifocal platform in their eye. It used to be bifocal, and now it's pentafocal. In terms of outcome, we have a preserved visual quality and visual acuity, and we do not compromise the optical performance. Now, in one of these patients, we did have a refractive retinal detachment after 1 year. Yeah, it's in the department of when you do surgery. There's no way you won't encounter any complications ever. The whole point is how to treat them and how to solve them. And then in our experience, and also from the design of this lens, I have these lenses in the drawer. So when I rupture a capsule, I have a multifocal, a pentafocal solution for my patients. That's it. I think I've said this, the take-home message. A very good defocus curve, excellent visual acuity in all distances. And in one piece, it's angulated. You can put it in the sulcus. Okay, now I'm up for questions. I don't have an ear thingy. Any questions? It was so boring that you don't have any questions. Oh my God. That may be a relief. The next year they won't ask me to come and talk. Please, I don't have ear. You have to tell.
Recommend capturing the optic or not?
Do I recommend capturing the optic or not? So this is a very good question. I don't have an answer. The thing is, I make my rexuses really smaller than the optics. In this lens, the design is such that the haptic optic junction is quite fat. So I haven't tried it yet. And because of the angulation, it pushes it back. I haven't needed optic capture. It's not like an Alcon lens with those thin haptics. I don't need it. So but I don't have an academic answer. More questions? Please. I need to listen.
If the pupil size is affecting the lens?
Oh, that's a very important question. So one of the questions here, and it's a very important question, is how do I look at the pupil size when I'm going for implantation? So, like with any multifocal IOL, if people have a really big pupil, I will not implant multifocal because they will get too many dysphotopsias. They will be chasing me. I'm not doing that. But then there is the other end of the spectrum, and that's people with very small pupils. So I saw in the presentation of GERD the graph in which it shows where the turnaround point is for far and near, for distance and near, etc. So we've had a case of someone with a pupil of 1.9 millimeters, and this man was adamant he had to have a C-lens MF. There was no intensity yet. And I hope that Yakir even remembers, we sat down, Alex, Yakir and I, and we looked at the graph and we saw that the turning around point for losing one of either functions, near or distance, was at 1.7 millimeters. And we implanted this man and we got excellent results. And so since that was, I think, more than 10 years ago, this is what I do. I explain it to the patient. I tell them, listen, this is the soft spot. And if it's not going to work, we'll have to see what we do. You can always do an argon pupilloplasty. It's a very rare procedure to do. I did it recently. It's a lot of fun. You just shoot on 10 spots in the middle of the iris. The pupil becomes a bit bigger. It's still responding, but the pupil is a bit bigger. So that would be the secondary thing. Does it answer your question? Thank you. More questions? Your questions are more fun than the talk, so please. No? Okay, thank you.